First of all, I'd like to say I'm here for two reasons. One reason, of course, is to talk about the oncology medical home, and the second reason is that it's almost impossible to say no to Rose Gerber. So that's one of the main reasons I'm here. So let's take it away here. So anyways, the oncology medical home is a new practice initiative to really do three major things. You know, everybody talks about quality and value, but what does that really mean? So the first goal of the oncology medical home is to enhance the patient care and improve the patient experience. The patient is first and foremost in the oncology medical home. The second thing is us doctors and healthcare providers need to be more thoughtful with our use of healthcare dollars. That's the second goal. The third goal is that we want to keep cancer care in the community where it's close to the patients. So, you know, the financial incentives have got to be rearranged so that, you know, the practices, finances are strengthened compared to what they are now. And the ladies from Columbus spent a lot of time talking about those particular issues. So we're all here, including myself, because we've been touched in one way or another by cancer. And these are my parents. My mother developed breast cancer in the mid-1980s when I was first starting my fellowship at Duke. And despite my knowledge and connections as a budding oncologist, we had to spend the most part of the 3 years of her life running around western Pennsylvania and western New York trying to seek competent, compassionate cancer care. And you know, she was lucky that she had me as an advocate because you know, most of the patients in my hometown that were treated by the oncologists there really got very poor care from a very poor doctor with a bad bedside manner. Now, fast forward 20 years later, my father developed pancreatic cancer, and fortunately, over those 20 years, community oncology has come a long way, and he was able to get excellent cancer care close to home. And as it turns out, he got his care from a colleague of mine that I trained with at Duke 20 years earlier. So, you know, the story had come full circle. As the ladies from Columbus had spoken, you know, community oncology is at risk. You know, all these gains that we've made in the past 20 years are threatened by our healthcare crisis. And so this is a fact that's not been lost on the COA board. And so about a year ago, they decided we have to take the lead for you know, leading the charge to be part of the solution and not, you know, be part of the problem. Otherwise, we're going to have a solution, you know, forced upon us that was not going to be in the best interest of the patients or the providers. So the concept that looked most appealing to us was the concept that was pioneered by Dr. John Sparandio in Philadelphia, Pennsylvania. This concept of the oncology medical home, where, you know, the oncologist would be the buck stops here doctor for the care of the cancer patient. And again, the goals would be to provide a better patient experience, be more thoughtful with the healthcare dollars by not doing procedures and treatments that were not necessary or appropriate, and hopefully, you know, get rewarded for doing that. So, just to give you a background to some of the crisis that the country is facing, just to give you a perspective, cancer care costs are rising at 15% per year, far outstripping medical inflation and even economic inflation. Drug costs are also increasing at 15% per year as well. So why are these costs escalating? Well, there's several key factors. One is we have an aging population. Cancer is an age-related disease. The longer you live, the higher your chances of getting cancer. You know, cancer patients are living longer, and in many cases being cured by better treatments. Now, what happens is some patients are unlucky enough to get second, third, and fourth cancers. And so, of course, that increases the cost. We have new therapies that may not cure a particular cancer, but can extend a patient's life, and of course, they utilize resources during their lifetime. We have drugs that provide a better quality of life for the cancer patient, even though they may not necessarily extend that person's life. We have drug treatments that we didn't have years ago for diseases like melanoma, which was a universally rapidly fatal disease, but now is treatable with some of the newer therapies that have just come online over the past several years. And then we have better diagnostic tools to better understand the course of a patient's illness, and of course that's very important for them to understand and be able to make appropriate decisions regarding their care. Now, the other part of cancer inflation, and I'm not throwing bad wishes on the drug companies, but these 5 drugs that you see here have come out in the past 2 years. The thing they have in common is a course of treatment costs $100,000 or more per drug treatment. And those numbers a few years ago were unheard of. So you can see that a few more of these drugs coming out at that price range, and it's going to continue to push cancer care costs through the roof. So, what does this mean to the average person? With these escalating costs, not only in cancer care, but in health care in general, by 2017 or so, it's estimated that half the salary of the average person will be the same price as their health care premiums. And by roughly 2029, it'll be 100% of an average person's salary. So again, this is a very real problem that affects all of us. So, again, getting back to what COA is trying to do about helping rein in healthcare costs without sacrificing quality, is that a Oncology Medical Home Steering Committee was assembled about a year ago. And the important thing about the steering committee was that we wanted to have involvement by the 3 major stakeholders. We had patients and patient advocacy groups, we had payers, and we had providers. So, from the patient representatives, we have Ms. Smith, who's actually a cancer survivor, and then we have representation from the National Patient Advocacy Foundation. And then we have other patient advocates as well. From the payers, we are represented by Dr. Newcomer from United and Dr. Klein from Aetna, along with some others. And then we have Dr. Sperandia, who's the founder of the Oncology Medical Home concept, on our steering committee as well. So the idea behind the committee is that, we want to take Dr. Sperandia's really brilliant idea, and if it just stays in Philadelphia, then it's not really going to do the community any good. So what we wanted to do was fine-tune his ideas and then make them scalable throughout the country so that this medical home concept could be disseminated to practices far and wide. So the first question to really get at the heart of what we were trying to do was the survey, which is what is quality and value, and we wanted to get the perspective of each stakeholder group. As was mentioned in the talk before mine, of course, different stakeholders have different opinions. So we wanted to get these opinions and make sure that we're meeting the needs of the 3 major stakeholders. And so myself, along with Bo Gamble and my administrator, actually surveyed all the stakeholders on the committee and got their definition of quality and value. And then when we met in Atlanta in February of this year, we had a chance to discuss each other's concepts of quality and value, and we were able to kind of come up with a list with stakeholder needs. Since we only had one patient representative on the committee, our practice also hired a consultant to get the input of about 20 of our patients, because again, the patient perspective is very central to what we were trying to accomplish here. So this is just some of the feedback that we got from our patients. These are kind of direct quotes. And you can get a feel for what really is important from the patient stakeholder perspective. But to kind of put it in a little bit more concise terms, obviously the patients want the best outcome. That shouldn't be any surprise. And not only is it just outcome, but quality of life is very important, especially in patients who have terminal cancers and they want to be able to plan out how they live their life. They want doctors with the 3 A's. They want doctors who are affable, able, and available. They want honesty about their diagnosis and prognosis, and they want to be engaged in the treatment planning. They want coordination of care. They want the least amount of pain and hospitalizations, and they want to have timely communications of their test results. Not only do the patients want a competent physician, but a competent office staff that's responsive to their needs is very, very important. They want least out-of-pocket expenses, and they want the availability of clinical trials. Now, the cancer care advocates had a little bit different perspective. You'd think their point of view would be similar to the patients, but it really wasn't. These advocates, really tend to work more with the patients in terms of helping them navigate the complexities of their insurance and benefits. So, those type issues were really important to the patient care advocates. And not only that, but that they had the social needs such as transportation and helping out around the home were also important to the advocates as well. So the payers, of course, wanted the best outcome for the patients, and they wanted satisfied members, but their focus, as you can imagine, was more on the cost of care and decreasing the variability of care. We met several years ago with one of the healthcare executives from Delta, and in that industry, the airline industry, which is very, very heavily regulated and heavily standardized, I mean, their whole team was in shock of the variability of medical care. And so standardization and evidence-based therapy is very, very important to the payers. And then it's not only important to control costs and have evidence-based guidelines, but then the practices have to be able to report back to the payers that they're giving the care that they say they are. And then for us providers, we want the best outcome from the patient as well. We want fewest hospitalizations for the patients because no one likes to have to get up at 6 o'clock in the morning to be able to schlep over to the office before office hours to see patients. And then, our key thing is we want less interference by third parties that kind of insert themselves between the doctor and the patient. This goes for, specialty pharmacy and pre-certs and so forth. In addition, we also need some help and some relief with, helping our patients get funds, particularly for the uninsured. That's a big cost for the practices that's not reimbursed currently. And then finally, we want to be compensated for our cognitive services, treatment planning, hospice care, that those areas of care are not currently reimbursed. So, basically what I just described there is what are the needs of the 3 major stakeholders? So if a practice could meet, the needs of those stakeholders, I don't think there would be any argument that particular practice was giving, very good quality care at a good value. So, so now that we've taken those broad terms, quality and value, and made them more concrete and actionable by the practice, the next step is to give the practices instructions on how they can meet those needs. And, I'll go through this somewhat briefly because I know many of you may not be clinical, but basically, it involves what I'd say here is best therapeutic practices, basically using guideline-based therapy not only for the cancer treatments themselves, but for other aspects of care such as supportive care, using oral compliance and persistence programs to make sure that if a patient's on an oral cancer drug, that they're taking that drug, and if there's a barrier or problem with them taking it, then we intervene early so that they stay on target. And then more and more importantly, as we move forward, we're better able to kind of dissect the genes within a cancer and then use that information to guide what treatments that we should give. In addition, there's going to be under development guidelines for radiation and radiology. Now, there's an old adage in medicine, it's better to stay out of trouble than to get out of trouble. So I think doctors are used to being, I guess, reactive to problems instead of proactive. And so I'm advocating they need to be proactive and really identify those patients who are at risk for developing toxicities and potentially long, expensive, costly hospitalizations, and getting those patients into the office daily if they need to, or if not daily, then calling the patients to make sure that if they're getting in trouble, then we can intervene early. In addition, we need to have responsive triage so that if a patient calls in with a problem, they get that problem addressed immediately. Okay. So the other aspect where we can control costs without skimping on care is to be more efficient in our resources. And that involves primarily, if a patient calls in sick in the middle of the day, we get them into our office and assess them in the office versus sending them to the ER. The second main area where we can control costs is compressing the length of stay. And that means, having somebody in the hospital that can help coordinate the care of that patient so that so that we can get things done quickly and then get that patient discharged. And then finally, has been talked about, making use of appropriate end-of-life discussions. I think we had some discussion about the lady with melanoma, for instance. I think one of the things that could have helped her particular situation is that the doctor's got to be clear with the patient and the family what the goals of therapy are and what the expectations are. And just because they're a young person, they got a bad disease like melanoma, you got to be honest and forthright. So again, the expectations are known by all involved. So we talked about the needs of the stakeholders. We talked about how the practices can meet those needs. The third part is reporting. We got to, as practices, be able to report back to the payers that we're giving the quality of care that we say we are. And so, the Oncology Medical Home Steering Committee, with all three stakeholders, have developed 16 measures which can be broadly broken down to patient care, to resource utilization, to end-of-life care, and survivorship. And these measures, as you see here, really have to do with the percent of patients getting treatment under guidelines, percent of patients with staging, percent of patients who are receiving a chemotherapy treatment plan. Again, this is to meet the needs of involving the patient in their care. And then the last 2 points really speak to guideline-based therapies. So resource utilization, of course, is very important for the payer stakeholders and to the patients because they have out-of-pocket expenses. And so two of the measures that fall under this is use of the ER per patient per year. and then the number of hospital days per patient per year. And then we have survivorship measures. Moving forward, this is not an area that us doctors are well trained, but as we're doing a better job curing cancer, then there are long-term issues that come up, and the patients and the referring doctors need to be educated on the potential long-term side effects of the treatment and be advised to look out for them and take the necessary interventions. And then finally, we have end-of-life care. There's way too many patients, in my opinion, that are being treated up to nearly the date of their death. And again, I think that's wrong, especially if you understand what the goals of therapy are and how good our therapies are. Some cases are not so good. So when it's clear that a patient's ability to function is fallen off to a certain level, then further treatment usually is not indicated, and then referral to hospice is. And so these are measures addressing that important parameter. So now the 16 measures that I just talked about really have to do with reporting the quality of care back to payers and other agencies that may be interested in what kind of care a practice is delivering. However, again, the patient's experience is a very important aspect of the oncology medical home. So the COA team has developed a patient survey based on the CAPS survey, and Carol Murtaugh will talk about that in just a second. So just to kind of summarize my part of the talk, the Oncology Medical Home Steering Committee has done a lot of work. We've developed the Oncology Medical Home Model. We've come up with the measures and surveys I just mentioned. We have an implementation team that's spearheaded by Bo and administrators from different oncologies around the country. And then, of course, the payment part of it is something I'm working on with a COA team as well. And this is the trickier part. All the big payers recognize that, they have to get away from paying from volume to paying for value, but they don't quite know how to get there. And so that's still a work in progress. So I started off my talk by talking about the patient, so I'll end with a patient quote. This was from the same meeting that Tom went to a couple weeks ago by this lady, Jessie Grumman. She's a 4-time cancer survivor, and I really liked it because I think it's really the essence of what we as doctors should be doing for the patient. And her quote is patient-centered care enables me to find good care and make use of it to achieve the outcomes consistent with my preferences. Again, the patient has a final say in their care, and that they got to be the center of the care. And it's not only you guys that need to be the advocates, but really it's got to be the providers and medical team being the advocates. And that way we'll be able to move cancer care forward and start doing business in a whole new way that's better for the patient and yet provides better value for the healthcare dollar.
As part of the Oncology Medical Home Initiative, one of the things that we've been challenged with is to try to bring all these pieces together into practices. So if you, heard Joan and Ruth's talk, you can understand that from a practice perspective, we're in a difficult situation right now in the community oncology setting. My role in the practice is I've been in my practice for 27 years. I started as their second nurse, giving chemotherapy when chemotherapy moved from the hospital setting into the practice setting. I worked in the practice as the clinical manager until about 3 years ago, and then took over the practice administrator role for a 6-physician medical oncology, 2-physician radiation oncology practice. multiple locations. Our main location is in a metro area, but we have rural locations, the farthest of which is 2 hours away from our primary office location. So I've been in community oncology a long time, and as many of you have family members that we've treated in our practice, and have seen how care has changed over the last several years. So with the Oncology Medical Home Initiative, I chair up a team of practice administrators to work towards bringing the goal to fruition in a practice of how to accomplish the pieces that we've all put together. So we're identifying information and services that will help practices. Obviously, as you heard from Ruth and Joan, we can't add more administrative burden or more cost to the practices, so we need to come up with some creative ways and tools that are in some cases already out there, some cases things that practices are already doing, and in other cases things that we need to develop ourselves to make sure that we're moving practices forward in this goal of practicing within quality and value. Our team is 8 practice administrators throughout the country, but we also have access to the co-administrators network, which is a huge network of practices administrators as well. So depending on what we're identifying, we tap into all of those resources. Some of the things that we're working on now are, as we said, really identifying what different practices need, and then also trying to establish kind of a roadmap, a how-to piece of where do we start and how do we get where we need to be, and a network of sharing best practices so that we can all get towards the goal. As we go through this, we're looking at different resource partners. This is really something that many of you may be interested in, seeing some of the tools that we've already come up with. You may have other tools that may be helpful in our initiative as well. We felt it was very important that there are no exclusive partners that we work with, because practices are all in different places, and so we can't be tied to one specific tool for a specific piece in the initiative. The tools also need to provide value to a practice. There has to be a benefit to them, and they have to be useful. And really, our tools have to be very customizable, so an a la carte concept, if you will. If you have a practice that has a large administrative staff and has more ability to do certain things, their need is going to be very different from a small, single, 1 or 2 doc practice in a rural community. So we need to make sure that we're addressing all of the community practices and helping them provide to them what they need for this roadmap. So we start with some information. There's information out there both on quality and value in cancer care, as well as the medical home concept. There are templates to assist practices. Many of these are things that a lot of practices are already doing. Maybe they just need fine-tuned a bit, or maybe they need some direction in how to do this more efficiently. Timely communication to patients, telephone triage, quick timing as far as new patient visits. So for instance, our practice has a policy, we see all of our new patients within 24 hours so that we can best serve those patients' needs from the beginning of diagnosis. We've taken the tools and put them into kind of 3 different buckets, if you will: patient management, patient assistance, and practice management. And I'm going to just give you a few examples of some of those tools and kind of how they relate to what we're doing within practices. From the patient management side, Dr. Gould talked about pathway compliance. So we've looked at 6 different pathway tools. Some of these are probably familiar to you, that will help to make sure that practices are practicing within evidence-based guidelines and using proven therapies so that we can obtain the best outcomes for patients. These not only allow for measurement of the physicians and how they're practicing within guidelines, but in the future we'll also measure things like how they'll do with follow-up care and with pieces as far as survivorship and other elements. Some of the tools that we've looked at are from the oncology specific distributors. They have a variety of tools on the patient management side that help with some pathway compliance pieces, clinical teaching, even practice management of the clinical pieces and the pharmacy piece within practices. We've looked at some survivorship tools. Cancer Survivorship Training, Inc. Is very interested in what we're doing, and we've had some great conversations with them as far as developing some survivorship plans and training for our practices. The ASCO survivorship templates are already out there. And we've also talked with cancer support community at length regarding their psychosocial distress assessment and their help with those areas, as well as the NCCN assessments. Patient portals will become a big piece of what practices will need to be doing in the future. There's a lot more connectivity from that perspective these days. Navigating Cancer is a patient-specific portal, but then also a lot of the oncology-specific EMR vendors are now coming out with their own patient portals as well to utilize for practices to communicate with their patients. For those practices that have the administrative staff, to be an ASCO COPE practice, that's obviously a great testament to quality in a practice. And then one of our information exchange tools that we've looked at so far is Medicity Inex, which is really an information exchange tool between providers in different groups and then also with payers. On the patient assistance side, these are things that you guys, I'm sure many of you are probably familiar with. Most recently, ACCC released their new updated patient advocacy assistance guide, which is a great tool for practices to help them with copay assistance and foundation assistance for all oncology products. Ruth and Joan touched on that in more detail. Then there's guides from NCCN. NCI has patient guides and tools that are really great for patient assistance, as well as some ASCO tools. And I actually recently, just this week, saw some great tools from the American Cancer Society that are really addressing the financial needs of patients and are brand new that are out that are really helpful that I think we'll be adding to this list as well. And then also in the end-of-life discussion, the 5 Wishes tool. From a practice management perspective, what we've done is we've tried to kind of start the roadmap with a readiness assessment. So there's an assessment that practices can take. It's a quick 1-page, not a big lengthy survey, but it just kind of gives them an idea of where they're at as far as practicing within a quality and value initiative. It asks them some questions so that they can kind of assess where they need to start in the process of working towards becoming an oncology medical home. There are other tools on the practice management side that the oncology distributors offer, everything from things that help with payer management and denial rates to practice efficiency tools that help within the practice within guideline adherence and a variety of things. Some other interesting pieces we found were from the National Business Group on Health, their cancer toolkits. If you haven't looked at them, I encourage you to do so. They are very engaged with employers about their employees and cancer care and how to manage those employees in the workplace and also how to manage that healthcare benefit. We have an E&M audit tool, some clinical trials budgeting tools for practices, and then also the ONS telephone triage guidelines. Dr. Gould talked about the importance of keeping patients in the practice and out of the hospital, and these are some great training tools to make sure that patients' needs are met when they call into the practice. And then also Dr. Sprandio's group actually offers some consulting services for those practices that may want to go that route in a more kind of in-depth dive in. So one of the first things that we were challenged with, the steering committee, as this being a patient-centered project, felt that it was very important to come up with a standardized patient satisfaction survey because currently there isn't anything like that out there in oncology care. So our team did some extensive research. We talked both, and took information from patients. You can see here, these are some of the points that patients felt were really important. And, we wanted to make sure that we address these in this survey. And some of these came from Dr. Gould's practice and the survey that their practice did. But, these were the things that we wanted to focus on as we put the survey together. We felt it was very important to use a tool that is recognized and standardized and felt to be credible. So we started looking at the CAPS provider-based surveys, And they also have a patient-centered medical home component, as well as some subgroups that have components on cost of care and shared decision-making and a variety of things that really fit into the issues that our patients wanted to make sure that were addressed. So we took the CAPS survey and we customized the questions from some of the subgroups and from the CAPS main provider, adult provider survey, and came up with an oncology specific survey for patients based off CAPS. At this point, the survey is being piloted in 5 practices. It's being done on a paper-based, but we have a tool for collection of the results that's automated and that we'll be able to use to benchmark practices against each other. So we're currently fine-tuning the scoring piece on that and putting together results from those pilot practices. And we should have the survey available to be electronic-based very soon. Next steps. So to this point, we've gotten together and, as Dr. Gould said, defined the measures. We're working on how to get those implemented into practice and then how to report on the measures and where we're at, and how we can then equate that to a payment reform piece with payers. So there's a payment reform task force that's been meeting that's talked about different models to look at different levels of payment reform for the community practices and how those will tie into measurements of quality and value and what those different payment reforms may look like. There's also work being done on a mapped tier for achievement. So for instance, you saw the different measures in the different categories. So if a practice is starting out and maybe they meet 2 or 3 of those measures, so they're tracking a couple of those things and can report those back to payers, that may be one level of achievement. And the second level, maybe you achieve 3 or 4 different measures in each of the buckets. And top tier would be achieving many of the levels in the buckets, but also maybe at a higher percentage. So 85% of our patient base is getting, this type of care, these specific treatments, or we're measuring at a higher level. So with that, our hope is to also then provide recognition to these practices. So we're in talks with several national organizations, NCQA. We're also in talks with the American College of Surgeons, Commission on Cancer, and a couple other organizations about recognition of the practices at different levels so that those can then be tied to, hopefully payment models. So maybe something as simple as if you're a level 1 recognized practice, your incentive from the payers is they say, okay, you're showing to us you're practicing within evidence-based guidelines, so we'll no longer require you to pre-auth any treatments. Those type of conversations and those type of initiatives to help everything come together from both the quality value care for patients, but then dovetailing into recognition and then hopefully payment reform. So that's all part of the implementation roadmap so that we can get into practices and have them assess where they are now and where they need to be to get to that top level of recognition, which is a great win for everybody because it provides quality value care for patients, it helps practices stay viable, and it helps payers continue to pay for quality and value care that's given in the community setting. So where do we find it all? So hopefully within the next couple weeks, all this will be unveiled on the new Oncology Medical Home website. So it's medicalhomeoncology.org. This is a snapshot of the home page at this point, and it's been really exciting to work on the development of this with the team. And it will have both places where providers and cancer centers and practices can actually go in and register their providers. And we have this out in testing to our implementation team and a few other pilot practices right now. And I think to date we've got 65 providers registered already on the site with that group. There will also be a place there where patients can then come and register. They can find a provider that's a quality and value provider. They can get information on the Oncology Medical Home and patient resource information as we discussed. And then there'll also be a place where payers can access the site. And then if permission is given by one of the Oncology Medical Home practices, they'll be able to go in and, for instance, access the patient survey results for that practice and see how they benchmark against other practices. So it's really bringing all the information together in one location for all three stakeholders to provide an access for what they need to do to coordinate care.